So, hi, I'm Claire Coleman. I'm a police officer with Police Scotland and work in the training, engagement, kind of evaluation side of the pathways. And I'll hand you over to Janice and her team.
Hi, I'm Janice Houston. I'm Associate Director of Operations and Nursing here at NHS 24. Hello.
Hi, pleased to meet you. I'm Gail McGregor. I'm the Head of Clinical Services with responsibility for the Mental Health Hub.
Hi, I'm Mandy Mackay, one of the Clinical Service Managers with the Mental Health Hub.
And that's us.
Mandy's off camera because we're socially distanced.
Yeah, no, that's good to see. And Emma's going to, as I say, unfortunately, she's in with she can't get off the meeting because she's in with the Cabinet Secretary, but she will be joining us. What we'll do is I'll kick off and just, when Emma joins us, she'll introduce it, her part, but I'll just kick off by uploading. We've got a small little PowerPoint for everybody. We're happy to take Q&A throughout. They can pop up the chat. Rory is going to assist kindly by assisting with the Q&A, post the PowerPoint little delivery for us, and we'll get cracking. But thank you for everybody to join us today. So I'll just share my screen. There we go, that's the PowerPoint there. So a nice little graphic. You'll see that some of us together as well when we've been doing some of our collaboration work. As the title says, it's a genuine collaboration between ourselves, Police Scotland and NHS 24. We also included in that collaboration is the Scottish Ambulance Service. But today we're just going to concentrate on NHS 24 and ourselves in the police. So
Claire,
we have our... Yes?
Claire, that's me joined.
Oh, right, perfect. Emma, what I'll do is I will come out of that and I'll let you do your introduction, Emma.
Hello everyone, apologies for my tardy lateness. As I say, I was in another meeting I couldn't get out of, but my name's Emma Croft and I'm a superintendent within Police Scotland. My role for this, although I've moved on a little bit, was to bring in the pathway into Police Scotland and to work obviously hand in hand with our colleagues from NHS 24. We'll talk about it, but it's been a very long but rewarding and very positive journey, which we're very excited about. So I'll let Claire run through the first bit and then I'll add a bit here and there as and when.
Right, perfect. So I'll go back to the slide again, and so we had our introduction. And this was our ambition. So really between the Scottish Government, because the collaboration is funded by the Scottish Government, we wanted, as it states there, they said, you know, we're looking at preventing and treating mental health problems. And we wanted to work more closely with one another, which is the collaboration. So, and look for health and mental health pathways. So for ourselves, we've got our unscheduled care facts. So people are 3 more times likely to attend the emergency department when it's unscheduled care. So it puts a massive resources onto our emergency services and a lot of demand on them. 1 in 5 people with the mental health calls to NHS 24 resulted in the attendance of the emergency departments. And greater than 60% of them is a mental health crisis and contacting NHS 24s. And as we can probably all evidence, that COVID has had a significant impact on ourselves in regards to the demand for all services, but particularly mental health wellbeing. So Emma, you could talk through the timeline for us?
Absolutely. So folks, our journey started at 2017, believe it or not, but a lot has been taken through in that time, and a lot has been developed, and a lot has been learned, and a lot has been shared in that time. So in 2017, myself and colleagues from both NHS 24 and the Scottish Ambulance Service put together a plan, essentially, which we took to our sponsoring body, which is the Health and Justice Board, which runs with Scottish Government and various, as I say, other key stakeholders. And that plan was very much to join that health and justice element together and to provide that pathway of care, which we knew was so vital in the communities. We knew we had a large tranche of individuals who contacted Police Scotland for help, and we also knew that we weren't necessarily the agency to provide that help, because a lot of those individuals were suffering mental ill health or distress and or social dilemmas. And again, we could only band-aid some of those at the time, but not actually provide the care and response that they required. So in 2017, we sought funding from Scottish Government And we also sought their support and their oversight, and that led to a collaborative journey over the last few years. I think it's fair to say that we hit a bit of a blocker when it looked like about the sharing of information and also the transferring of calls and what that information was in terms of GDPR. And that took a big chunk of our time to overcome that. But what we've ended up doing is circumnavigating it, working around it. And we have, as I say, a pathway at the moment that we will build upon in the future, which is absolutely fit for purpose. Back to August 19, when we had the go-ahead from our Information Commissioner that we could work in the way that we hoped to going forward, and we could share the information the way we were looking to do, which was the transferring of information over the phone at that time. We put together collaborative training between both organisations, and I think it's important to add that that's the first time we'd ever done anything like that, and I'm sure our NHS 24 colleagues will come in and reiterate it. That was significant, and significant from a policing perspective, because we in the policing world, particularly in Police Scotland, we're a bit scared of the mental health picture, if I'm being honest with you. Our staff didn't have the confidence to ask the questions that might need to be asked and to deal with the potential answers to that. So to have that training and things like suicide awareness, those difficult questions, was absolutely paramount for us to be able to build that culture and that confidence within the police force, and then obviously to link it into the NHS 24 provision of care. That collaborative training, which Claire can maybe give you a little bit more information on, which has been recognised and, as I say, from externally and, as I say, graded well, then led to us putting together, as I say, a package that we then trained out to all of our staff, and likewise was also shared with NHS 24 as part of their particular training product as well. In October 2019, you see from the slide there that we actually presented our initial steps at the LEF conference last year, which was, as I say, met with some really good questions and some really good points in collaboration. And we took some of that shared learning at that conference and took it forward as part of our delivery. In February, March 2020, we took the testing scenarios forward. Now, bear in mind, at that point, we were just about to eclipse into the pandemic as we know it. We had a rumblings of something going on, so we were very, very keen, knowing what was possibly ahead of us, to make sure that this landed on time. So those test scenarios we put into place in February, March, leading very quickly into the live scenario in May 2020, whereby we were very much within the realms of the pandemic at that time, and our demand was significant in terms of those reaching out to us for help and support, given the difficulties many were experiencing. From May 2020, we then moved into August 2020, which was when we actually launched the collaboration. And I think it's fair to say then that it was a slow and steady start. You know, we were referring calls, which Claire and my colleagues will talk about going forward, as the detail of those, in a slow and steady format. But that was good because it allowed us to evaluate as we went. It allowed us to review the circumstances of each call and each referral to make sure they're fit for purpose. And importantly, to provide our executive the assurances they were looking for, because I think it's important to say that never before had we as a police force in Scotland actually transferred that area of risk to another agency at the first point of contact, which is individuals calling us for that support. So this was a big, big journey for us, and one that we were very keen to kick glove and make sure that we were completely comfortable with before we actually moved on and built the model even further, which again, we'll talk about. That takes us through, as I say, to this year, where, as I say, in the next few slides, we'll talk about the actual process itself, but it takes us through to this year where we can give you some figures, facts and figures as to where we are now. And I think it's Janice is going to take over from here, is it, or is it Claire?
No, it's Janice.
Yep. Okay, so what is the Mental Health Hub? The Mental Health Hub is a core part of our Treble 1 service here in NHS 24 in Scotland. And it's the Treble 1 service is the only option in the out of hours to access healthcare in Scotland other than dialing 999 or just pitching up at an emergency department. So what happens, we did a lot of user research before we started on the long journey with the Mental Health Hub. We were told by users of the service they wanted to tell their story once. They wanted an empathetic response. They didn't want to be passed from one person to another person to another person. So the public phone 111, and then the first option they have on our IVR is to press 1 if you're calling about your mental health or well-being. So they press 1, they come through to the Mental Health Hub, and the person who answers the phone is called a psychological wellbeing practitioner. These are individuals from multiple backgrounds. Some are psychologists, some are actually mental health nurses, some are just general, have had a long life experience in working with people with mental health and wellbeing issues. So they know why these patients are calling, and they answer them with an empathetic response. They know why they're there, they know it's about their mental health. So that's one way to access the Mental Health Hub. Another way now is, due to this collaboration with Police Scotland, is people actually phone 101, a similar number, to Police Scotland, and actually it's then ascertained that the caller would be better served by coming into the health part of the Mental Health Hub. So Police Scotland transfer the call over to us and we take that call forward, but we can talk about that in more detail later on in the presentation. So when you're through to the psychological wellbeing practitioner, they take you through a tool, an assessment tool, to work out, you know, some people do call us and they're in great stress. So some of our outcomes might be, we pass the call from a psychological wellbeing practitioner who's supported by a mental health nurse, and indeed a senior charge nurse, which is a more senior mental health nurse. And so they can take the person through to either a self-care outcome, or indeed that they are more unwell, therefore require a clinician to take over the call. And indeed we have the option to electronically transfer these patients' callers, if required, on for further support to another agency in the 24/7. So will I pause there? Claire, you want to go on? Or so?
To what we've kind of established so far. So the reasons where people have made contact with the hub, this was some that we've identified across both services. So and people feeling suicidal, low mood, anxiety, you know, the self-harm, obviously, problems with neighbours and COVID and such like. Yourself, Janice, is there anything from Mandy and Gail's side if they'd like to discuss the reasons for that people have, you know, between the police and the direct contact from NHS 24?
No, I think the first 4 or 5, Claire, it's Mandy here, that would tie up with our calls, and definitely seen a huge increase in COVID-related mental health issues, especially with homeschooling, loss of jobs, addiction. All of these things are coming to the fore, and just the fact that people are isolated, so that kind of ties in with everything that you've got there.
Yeah, and I think that the key part is, you know, and we do have a lot of issues with addiction and loneliness just now, and you know, it's not the right response for the police service to have to send down 2 police officers to support these individuals. It's far better for the person as well that they're supported through the Mental Health Hub. So yeah.
Certainly for us, we found quite a rapid increase with people with problems with their neighbours, and that's purely because people are at home now a lot more, and the slightest thing is really kind of aggravating them, which is COVID related. You know, people weren't previously at home as much, or homeschooling, and the neighbours problem certainly is a great factor. We've also found for ourselves, one of the reasons people get back in touch with us is because of our own contact with them. So they've maybe been through the criminal justice system, so that's where they've been arrested or they've been interviewed, they're a witness, they're a perpetrator, they're an accused, and they actually get back in touch with us looking for support for mental health crisis as well, which is quite a strange, you know, a 360 cycle for people in regards to that. I'll move on to the next slide now, Janice, if you could discuss.
This is just really, you know, in summary of what we've been seeing. So 777 referrals have been assessed and managed by NHS 24's Mental Health Hub staff between August 2020 and February 2021. 97% of these calls were successfully passed from Police Scotland to NHS 24 Mental Health Hub between December 2020 and February 2021. We've also 3 innovative initiatives implemented as part of the collaboration. We can talk about that in the Q&As. And 93% of referrals to the NHS 24 Mental Health Hub had a non-emergency endpoint. I think that's really important. We managed to support them into over 60% into a self-care environment with supportive materials, etc. So I'll just pause there.
Yeah, and that's us really come back to ourselves now. That's us come back to the end of our short presentation, and now we're quite happy to take questions. Rory is going to kindly assist and make us aware of the questions. But any questions people have, please ask away. No, there's no questions as yet. I suppose I can discuss about the three innovations. So one of them is what I briefly touched about before, is in regards to people who've been through our criminal justice system. So they're getting back in touch with us. They get back in touch with police and looking for assistance with their mental health crisis because of their journey with the police in whatever way, be a witness or be a victim or a perpetrator or an accused. So as part of when people are being released in custody, we will be producing it along with all other services that are available to them about addiction and health support and that. It's a custody release leaflet, and it'll also include the hub's details in it as well as all the other great services that are out there. So that'll be beginning from the beginning of April. Another part of it is that we're looking at all our police officers and relevant staff across Scotland. So that could be for a station assistant who works in Benbecula right through to the cops in Edinburgh City, that they'll all be made more aware of the services within NHS 24 and breathing space and other great services too. And we've got a little question.
We do have a question. Do you want me to read it out loud, or can you read it?
Yeah.
Great. So the question from Pat is, one of the issues that our policing agencies have raised that contributes to their support of behavioral health support is that there is a reduction in the amount of time that the police are spending on these issues. Have you gathered any data on reduction of police time or amount of time that your MH Hub members are spending?
Yeah, so for me, from a policing side, every time we refer, so we're over 1,000 referrals now, and we do not deploy to that. So there's an immediate saving, but we're getting the person on the right journey at the beginning. So it's that first point of contact. So for us, we pass it over to the service, which knows how to deal with it and are the experts in this field.
Claire, it's maybe worth saying, for what we in Police Scotland consider as a kind of deployment for police officers can be anything up from 4 hours onwards for a mental health or wellbeing type call. So if you can imagine, if we're up to 1,000 calls that we have now successfully referred to NHS 24 for the right support, we could multiply that by the 4 hours very crudely. However, I think it's very honest to say that we've not done that yet, and the reason we've not done it is twofold. One is because we're in the middle of the pandemic, so our figures are all over the place in terms of our demand, but two, what we are also seeing is an increase in demand from the vulnerable individuals in our society and the complexities that comes with. So we might still end up dealing with a big chunk of mental health or mental wellbeing demand, but it's significantly more complex and is wrapped up in either criminal activity or social wellbeing issues that we have to attend. So that's not to say we won't at any point work out what time has been saved going to NHS 24, but what it has allowed us to do actually is concentrate on those more complex issues going forward, because if we didn't have the pathway, quite simply, we would be on our knees because, as I say, of this type of demand and the complexities that are coming our way.
And probably I would just add, from a health perspective, we spent a long time planning this, and we spent a long time working together to decide on the criteria for the calls that are indeed passed over from Police Scotland to NHS 24, and that's hugely important because we're then managing these calls appropriately and not passing people between services inappropriately. So the groundwork for this initiative is so important.
Great. Oh, I'm sorry, was there more?
No.
Great. So Pat said thank you, and we have another question that states, you mentioned about GDRP. The person states that they're currently looking at triage schemes in England. Please, could you describe what the key info sharing issues were and how this was resolved?
Yeah, so it's GDPR, and I suppose just to simplify it, because it was very complex at the time, is we have a system in Police Scotland that records cradle to grave. So when a member of the public phones us, whether it be on the emergency or non-emergency line, the recording kicks in at that particular time. Only when the individual who calls us hangs up does that recording terminate. So the issue we had is we wanted to do what was called a warm transfer, which was to hold the individual on the call and transfer them directly through to NHS 24 to save that individual having to phone back and a cut in the line. We couldn't do that because it would still continue to record when it hit NHS 24. And there was a big discussion as to whether we in Police Scotland were entitled to have that recording, which contains sensitive and could contain medical information. Our argument was that we did need that in terms of, our main purpose for being, in terms of the care and well-being of our society. However, the GDPR and the Information Commissioner decided that that was not the case, and it was a virtue of our system rather than our need that we would record. So as I say, we were not allowed to go down that route, and as a result, we had to change the model slightly to ensure that we weren't recording information we weren't seen to be entitled to have. So apologies, that sounds quite complex. More than happy to take that off table and have a discussion if it impacts on your own particular work.
Great, thank you. So we have one more question at the moment, and it asks, can you talk a little bit about how this collaboration has bridged the different professional perspectives of individual needs?
Yeah, I maybe start it off and say that we, right from the beginning, we shared so much together, be it our learning and our training, and joined in a collaboration in that way, that we just didn't take it for granted, certainly from a police side, that we actually knew exactly what NHS 24 did and how their PWPs worked and all the different roles, and neither did NHS 24. We took the time to understand each other's roles and how we can benefit from each other and understand that. So, and then that was then shared when we done our training, because we jointly trained and delivered together, and as well when we were running our test and our scenario work and then our live work, that we were open, we could have good conversations, honest conversations with each other about how we think that things are working, how we can make it better for the journey for the person. And that's really been all the way through from the beginning. I don't know yourself, Janice or Emma.
Yeah, I'm going to hand over to Gail, but I think most importantly between both services, we kept the person who was calling at the front of the conversations. There was never any criticism of either service. Whilst we did a lot of call listening to scope out what type of callers we should be moving between services, etc. But we all kept the person or patient, as we call them, at the front of the conversation. I think that's the most important thing, that really other people's thoughts and views weren't as important as what the journey for the patient would be. But Gail, Mandy?
Yeah, I think from my perspective and from a professional perspective, it has also facilitated a co-working situation where you haven't phoned the wrong service, but you've phoned a service whereby we will direct you to the best person, because we are working as part of a collaborative. So it has allowed the public to see us as a working collaborative, rather than phoning the police, you've phoned the wrong service, phoning health, you've phoned the wrong service. So it has, without a doubt, joined pathways that otherwise we wouldn't have been able to engage in.
I think just to add to that, Claire, we've also found a few things that both sides would like to know more about. So like our team would like to know more about what police are doing, and that's led us to be working on a new piece of work where we're going to do some more joint training. So I think it's forever changing, and it's evolving at some rate very successfully. So I think the understanding of the roles is growing. The more confident we're becoming working together to ensure that these patients are getting the best journey.
Great, thank you. So our next question is, if you had a magic wand, how would you develop this service further?
I would get more staff so that we could answer more calls, because the need is there. But these staff, they're highly skilled, highly trained, and getting the right staff is the right thing for us to do. And I think that, you know, we've had a magic wand in that we developed this as a team, and we work as a team. The mental health hub works as a team, and I think it's that's why getting more staff in very quickly is so difficult, because you want to keep the team concept, you need the right skills and training, etc. So yeah, magic wand, more highly skilled people, that would be what I would wish for.
Yeah.
I think we're working towards already stuff that's a magic wand, which is, you know, bringing in roles that will provide, wherever you phone, on-site support and appropriate support to patients who otherwise wouldn't have had it, and looking towards potentially supporting the police on the ground who are out on other calls to be able to support mental health as part of an overall intervention with an individual. So these are things that we definitely have on the horizon, and to go back to Janice's point, we could facilitate them very quickly if we had a magic wand to give us the correct practitioners to do that.
Yeah, I'd absolutely agree with what Gail's said, what's been said. The magic wand for me would take that even stage further than what Gail's talking about. And whereas we look to the future, we have a real joined up approach to health and justice. And that one, you know, that one touch, any individual can phone either service or be in touch, and we can refer, and it's a seamless pathway for them. You know, I see mental health nurses and PWPs working within our control rooms. I could see that working the other way, and I could see a very, very joined up approach, one which we're working really hard towards now. But going forward, I think there is so much more that we could do together to make the outcomes better for individuals.
Yeah, you know, for me, I would go back to us in Police Scotland having a better telephony system, and because it would have saved us and to this day, you know, I bet if we had that, a more modern telephony system, and well, that's a good couple of million to pay for that, then it would be a more effective journey for our own people who work in the police, as well as the people who are calling in at that, just from our basic referrals. Any more questions, Rory?
None at the moment. Yeah, nothing in the chat or in the question and answer box either.
I suppose it's fair to say that we are looking at new things, the new steps, and we're certainly working that. And Gail's made mention of that in regards, we're looking at nurses and mental health nurses and such to be working 24/7 with the police in live scenarios and incidents, and certainly moving towards that. But you know, there's so many little bolt-ons you could add with that, you know, professional to professional. So police officers are out, and as technology changes, it'll work better in that way. That you know, you can use video conferencing if you're out at a scene, and then you get to speak to a professional a lot quicker. But really, it's Janice, you know, has said, and Emma says, we all say we're always thinking of the person. What is the best route? What's the best journey for this person to receive support and help? Yeah, I don't know if there's anything from anybody else, yourself, Emma or Janice.
No, that was all. Thank you very much.
Yeah, thank you then.
Thank you.
Thank you.
Bye.
Thank you.
Thank you, everybody. Thank you, Claire.
Oh, thanks, Rory. You take care of yourselves.
You too. Thank you.
Bye.
Bye. Thank you, Inga. Have a great day. Hi, Kelly. I see you're the only one left, but the presentation ran a little bit shorter than the hour and a half that we expected. So I am going to close the room shortly. I just want to give you a second to do anything that you need to do. No problem, Kelly. I'm gonna close the room now, actually. So have a great day.